the faculty of the institution. Second phase is start. Each day has been given to each stakeholder of who has contributed in the development of SCB Medical College and Hospital. Now, the third page is on 26th, 27th, and 28th. And I extend a warm invitation to all participants, all the alumni, and all stakeholders to SCB Medical College, Cuttack. Please join us in the jubilation for the Platinum Jubilee. Now, from 13th, we are having every department is celebrating a day depicting the glorious history of SCB Medical College, Cuttack. So, and be part of the jubilation. The speakers, faculty, guest faculty that we have invited. We are going to felicitate all the for 75. We are live streaming all the program. In case somebody is not able to make it physically, then please join us through the link, which will be provided by all the HODs of the departments. I welcome you again, and I request to all alumni to become a registered alumni member. Please visit the website of the Alumni Association of SCB, which is known as SCBNs. It is scbmchalumni.in. I will send it in the chat box also. So please try to join as early as possible, and let's make SCB together one of the best institutions in the country and, if possible, in the world. Our government has taken all the initiative for the mega expansion. We are going to become a 5,000-bedded hospital, high-tech of a world-class facility, and each one of you can contribute in the development as regard the academics are concerned. So we are always there to be guided by all of you as regard how we can progress to make SCB Medical College in world to be reckoned with. Now, again, I extend a welcome and hand over the proceeding to Professor Jain Behera to conduct the CME. Thank you.
Thank you, sir. Good afternoon to all of you, those who are participating in this pre-Platinum Jubilee CME for the Department of Pediatrics. I also welcome to our speakers, Dr. Sonali Mahapatra and also Dr. Susmita Sarangi in this CME. A brief introduction for this pediatric cancer will go for about different aspects of the pediatric cancers. As you know, this adult oncology is the most developed branch of medicine in India, but still pediatric oncology is a developing one. Since last 30 years, these major advances have occurred in the field of pediatric oncology, and we are in a better position to understand the subject, and which will also influence significantly understanding of the subject and also management outcome of these disorders. As you know, as the infectious diseases are controlling, and also there is eradication of the malnutrition, so more children are now affected by the cancers. So that it is observed. And as per the estimates, in India, about this population-based cancer registry, 5% of the pediatrics population, pediatrics patients, among the total pediatric cancer patients, will have cancers. So if you count it, we have 40% of the pediatric population in the general population. So it accounts for the 50,000 new pediatric cancers to diagnose annually. And also, it is difficult to detect also pediatric cancer. As you know, that there are certain cancer symptoms that they are non-specific, and that will not be carried out. So you cannot think about that this patient will have also cancer or not. So that is very difficult to also detect cancer. And certain mimicking factors, clinical features also certainly mimic this pediatric cancers. And the type of the childhood cancer and the cause, the response to therapy, they are also differing from this treatment on the diagnosis of the adult. It is very particular that in childhood cancer cause and also response to therapy also they, because these children they will present say very in the critical conditions, and if you start treatment, they will also response is also good as equal. And the overall survival rate is more than the 80%, particularly in developed countries and in some of these centers in India. So, the first topic that we have allotted, that the overview of the pediatric cancer, that will be taught by, that will be delivered by Dr. Sonali Mahapatra. And you know, the Sonali Mahapatra, she is also in Peadiatric, and she graduated from MKCG Medical College, which in 2001, and MD Pediatrics in 2006, and DM Pediatric Hemato-Oncology in PGI Chandigarh in 2015. She worked as senior resident in the Department of Pediatrics at Medical College from 2009 to 2012. And now she joined in AIMS Bhubaneswar in 2016 and working as Associate Professor, Department of Medical Oncology and Hematology, AIMS Bhubaneswar. The second speaker is Susmita Sarangi. She will speak about management of the pediatric cancers. She graduated from Grant Medical College, Mumbai, India in 2005 and MD Pediatrics in SC Medical College in 2003. She got her fellowship Pediatric Hemato-Oncology in Stephen and Alexander Well Children's Hospital, North Shore Long Island Jewish Medical Center, New York, at 2014, and worked as senior resident in Department of Pediatrics, Tony Brook Children's Hospital, State University of New York, in 2009 to 2011. Now she is working as Assistant Professor, Department of Pediatrics, Division of Pediatrics, Adolescents and Young Adult Hematology, Oncology, MedStar Jurston University Hospital, Washington, D.C. since 2019. Her work has been published in various peer-reviewed journals and textbooks. She is a very dedicated cancer treating physician. So to start with, first the overview of the pediatric cancer, I request Dr. Sonali Mahapatra to start to deliver talk. Dr. Sonali Mahapatra.
Thank you, sir, for this introduction. Respected Principal, sir, of SC Medical College, Qatar, and Professor Jane Behra, Professor and HOD Department of Pediatrics, SC Medical College, Qatar, and Subodha sir. So I'm really privileged to be here and a part of this Platinum Jubilee celebration of the Premier Institute SC Medical College, which is my alma mater also. And thank you again, sir, for giving me the opportunity to speak on this platform. Sir, my screen is visible?
Yes, visible.
Yes.
Yeah, it is visible. Please go ahead.
Okay, thank you, sir. So I have been given the topic to cover overview of pediatric cancer. So it's a big topic. And today, 30th August, we are discussing this, and September is the childhood cancer awareness month. And this ribbon, that is this golden ribbon, it is the symbol of childhood cancer awareness. So because time is short, so we will limit ourselves to the incidence of pediatric cancer and what is the difference between this pediatric cancer management in developed or developing countries, and what more can be done, and regarding the diagnosis as well as management, supportive care, and of course for this review of this long-term survival. So in the world, every year, around 4 lakh childhood cancer cases are diagnosed, and in India, it is around 50,000 childhood cancers are detected every year. And when we see that this detection rate is around 50 to 60%, but in the developed countries, as we can see in the developed countries, it is much more. So they are able to pick almost all the cases which are of pediatric cancer, but maybe we are lagging behind in diagnosis, or because of the lack of diagnosis as well as reporting and documentation. As we know here, we have poor documentation. So there is stark difference between this as far as the childhood cancer treatment goes in developed and developing countries. So the incidence is around 45,000 per year in developed countries, where the huge number of pediatric cancer patients are diagnosed each year in the developing countries. And in the less number, and their survival is very high, around 80% of 5-year survival rate. And most of these advances has been made in the last 4 decades in pediatric cancer treatment. But here, if we see that in developing countries, around 30% 5-year survival rate. So the developing countries are actually contributing to the maximum number of death in the pediatric cancers. And Indian data somewhere lies between this around 50 to 60%, because most of the Indian data are institute based. So different institutes have different data. Naturally, those institutes with good supportive care and already established, they have good survival data than the new institutes where a pediatric oncology facility is not available. And if you see, then this incidence in the pediatric cancer is around 38 to 124 per million children per year. And as I have already said that in metros where the facilities are available, so the incidence is more because they are able to pick more cases or diagnose more cases. And in other areas or remote areas, so patients may not be being diagnosed. That's why the incidence is less in those areas. Then what are the most common childhood malignancies? So as we see that this acute leukemias are the most common diagnosis of childhood malignancies. So it is around 34 to 35% of all the childhood malignancies are contributed by acute leukemia. But as is followed by CNS tumors, then lymphoma. But as age advances, so this is the global data. As age advances, then this lymphoma number increases. So then the acute leukemia number decreases. But if you see around 14 years of age in the pediatric population, this acute leukemia is the most common diagnosis. And this is the actually country-wise differentiation of incidence of the pediatric cancer patients. So as we can see, this is South Asia. So this South Asia, but it is actually Indian data, because in South Asia only India has participated in the study. So here also the same scenario, like leukemia are the most common diagnosis, followed by lymphoma and CNS tumors predictably same in number. So what are the causes of childhood cancers? So as you know that there are many predisposing factors are there in adulthood cancers, like external factors starting from tobacco smoking, smoking, alcohol, obesity, and this non-healthy lifestyles. But in pediatric cancers, most often hello. But in most cases, the cause is not known. And genetic factor predisposition is seen in around 10% of cases, like those patients who are diagnosed with Down syndrome or other syndromes like Lee-From-Nimini syndrome or Fanconi anemia. So these are the genetic factor predisposition which is present for childhood cancer patients, but that is only around 10% cases we'll find those cases. And the environmental exposure like radiation or external factors like chemicals or this virus like EBV virus which can cause Hodgkin's or Burkitt leukemia, that is also very less in 10% cases. So most of the cases, like in 90% cases, we will not find any cause for childhood cancer. So what is the difference between pediatric cancer and adult cancer? So as we have already discussed, sir was telling, so the incidence is low. So around 5 to 6% of all the total cancer incidence is contributed by pediatric cancers. So the incidence is low, and as a diagnosis, there are actually two peaks. So the first peak is between 0 to 5 years of age, and the second peak is in the adolescent age group, where we find this like bone tumors are common and lymphomas are common. And of course, in adults in older age, we see more. And the common malignancies, we have already discussed that leukemia, lymphoma, CNS tumors are the common malignancies. So that's why this hematolymphoid malignancies and tumors derived from the embryonal tissue, like this neuroblastoma, these are more common, sarcoma, these are common. But in adults, this carcinoma derived from epithelial tissue, these are more common. So we have discussed that in pediatric cancers, we hardly see any acquired risk factors, but of course there are acquired risk factors are common in adulthood cancers. And this chemosensitivity and survival is much more in pediatric cancers. That's why we are giving emphasis on early diagnosis and treatment, because survival is really good in pediatric cancers if we pick up at the right time. But in adult cancers, the sensitivity and the survival is very poor. And as the patient is like diagnosed in the pediatric age group, and if he survives, then he has to live a longer period. So as the child grows into adulthood, so some long-term effects, which may be the side effects of this chemotherapy and radiation therapy, that may come up. So we have to look for the long-term effects of treatment of childhood cancer, and that may be problematic in the long run also. So is there any preventive means? So because known, most of the time risk factors are not known, so preventive measures are also no preventive measures. So known risk factors, that's why no preventive measures. And screening tests also, like if we leave aside some malignant predisposing conditions or like syndromes or familial retinoblastoma, where screening test will help. But most of the time the cause is not known, so screening test is also not helpful, and definitely it is not caused by the lifestyle. Then what are the warning signs of cancer? So if we see this like severe anemia and bruising or bleeding, then any swelling anywhere else, especially if the swelling is painless and associated or not associated with fever, then unexplained weight loss, persistent of cough, sweat at night, and eye, like in retinoblastoma, the eye changes if you see like white reflex. Abdominal swelling that we have to examine. Suppose abdominal swelling, it may be neuroblastoma or Wilms tumor or hepatoblastoma. Or in case of brain tumor, there may be vomiting, severe headache, and limb or bone pain without any obvious trauma or signs of infection. So these are some of the warning signs of cancer, which can lead us to that we can think of that it may be something else, not infection, or which non-malignant conditions we are very well come across. So we have to think that it may be something else, and accordingly we can go for the diagnosis. So there are some signs and symptoms which actually of childhood cancers that can mimic the other non-malignant condition. So that's why most of the time, because of this, the diagnosis gets delayed. Like fever, it may be present in leukemia, lymphoma, but we know that most of the infection that can cause fever. Vomiting may present with abdominal or abdominal mass or brain tumor, and that may be due to any infection or GE reflux. As well as cough can happen with mediastinal mass or respiratory tract infection. And of course, in bone or muscle pain can happen with leukemia or bone tumor or neuroblastoma. Also, it can happen with injury or any viral infections. Headache can happen with brain tumor or other like infection or tension headache like this. So other systemic infections, lymphadenitis can also cause lymphadenopathy, and hematuria, UTI, and glomerulonephritis also immune tumor can cause. So because there is overlapping of the symptoms of childhood cancers as well as other non-malignant conditions, that's why sometimes the diagnosis get delayed because of the lack of suspicion. So as we describe the childhood cancers, mostly they are either hematolymphoid like leukemia, lymphoma, and others like leukemia like ALL, AML, or CML, lymphomas like Hodgkin's or non-Hodgkin's. In non-Hodgkin's, these four are more common like lymphoblastic lymphoma, Burkitt lymphoma, or diffuse large B-cell lymphoma, or anaplastic large cell lymphoma. Others like Langerhans cell histiocytosis or hemophagocytic lymphohistiocytosis may be seen. And solid tumors like brain tumors, as we have discussed, or eye tumor like retinoblastoma, bone tumors like Ewing sarcoma, osteosarcoma, and abdominal tumors like neuroblastoma, hepatoblastoma, germ cell tumor, Wilms tumor, and other soft tissue sarcomas like rhabdomyosarcoma, as well as other sarcomas that are called as non-rhabdomyosarcoma, soft tissue sarcoma. So because this leukemia is the most common diagnosis, so we should anticipate when to anticipate that it may be a leukemia. So the common symptoms are like weakness, loss of appetite, pallor, fever, easy bruisability or bleeding from any other side, bone or joint pain and tenderness. So it may be so severe that a child will not be able to sleep at night, and swollen lymph nodes. Lymph nodes may be in the cervical area or axillary area or in the inguinal region with enlarged liver and spleen. And it may be associated with frequent infections because of this immunocompromised condition and unexplained weight loss. So these are the most common criteria. Similarly, in brain tumors also, we know that we have already told that vomiting may be there, or headache, vomiting. These are the more common findings. Also, it may be associated with double vision or facial weakness or ataxia. So if or altered mental status, seizure. So these things are should be taken into consideration. Then we see, of course, it can be seen in the other like orbital rhabdomyosarcoma also. But this retinoblastoma that we see in these phases are rarely seen in the developed countries. So most of the time in the developed countries that have been picked up with the white reflex stage. But here we see all in the like late stages, these sort of things. So if we are talking about early diagnosis, then how we can go for early diagnosis in our setup. So it is always like three components, like initially awareness by the family members. So family members should be think that something is not right with the child, and they will go to the primary care providers, and the primary care provider should have actually so do the clinical evaluation, and it should have suspicion so that we can go for a diagnosis and staging, and there should be access to prompt treatment. Then only early diagnosis will help. So like late presentation we are talking about. So this sort of tumors we come across here, it will be hardly seen in the developed countries. So what is why they present so late? Because as like in the pediatric practice, we have most commonly come across these marks, and most of the time they will waste their crucial time when we can do the early diagnosis and management, but they will wander for all this this godmen for this tantric and other things or other medicines. Then in the late stage they will come to us. So what are the challenges of late diagnosis? When we see the late diagnosis, so one of the factors that this survival is very high in developed countries because they are diagnosed in the early phase. But most of the time we see all the cases in the late phase. So when we see late diagnosis is made, means patient will be in the more advanced stage, and it will be more advanced stage means requires more intensive therapy as well as lot of supportive care. And often the patient, because of the prolonged illness, patient will be having multiple comorbidities like malnutrition, because of loss appetite, as well as cancer cachexia and malnutrition, and it will be like super added with infection. And when the tumor size is very big, and like in the leukemia with hyperleukocytosis, etc., so there will be chances of tumor lysis syndrome, then this renal failure, and increased treatment related death. So because of this comorbidities, as well as because of the late presentation intensive therapy, so that may land up in more of treatment related mortality and morbidity. So what are the obstacles for good survival care in our setup? So obstacles for good survival care, first is the diagnostic failure, as we are talking about, then treatment related mortality and morbidity, and treatment. And even if the patient comes for treatment, then after some time they will abandon the treatment. So how can we reduce the diagnostic failure? So most often for diagnosis, we need some like biopsy should be done, histopathological study, and IHC, that is immunohistochemistry, and in liquid malignancies from the bone marrow sample, immunophenotyping. So these are the routine and standard done in the standard pathology departments. So if our laboratory setup will be like this, then most of the time we will be able to diagnose. So these are the simple techniques: immunophenotyping, biopsy, and immunohistochemistry. And imaging studies are most of the time it is available, either CT scan. If PET scan is available, it's very good, so that it will help us in the picking up the malignancy as well as in the staging workup. But if it is not available, it's okay. So with simple CT scan also and MRI, which is more often available at every setup, then we can do this thing. So with these basic things like imaging, CT scan, and biopsy, histopathological study, IHC, and immunophenotyping, we'll be able to diagnose maximum cases. Then what is the treatment related death? So this treatment related death is the the leading cause of treatment failure in the lower and middle income countries, which is India actually comes under LMIC, that is lower and middle income countries. So around like 1/3 of the high risk cases, we find this treatment related mortality or morbidity, because in the first month of therapy, this supportive care is mostly needed, because of whether it is like blood product, or it is maybe glutamatational mass needs ventilator care, or a patient with high tumor burden, patient lacks with tumor lysis syndrome and requires aggressive hydration, and or with hyperleukocytosis. So all these cases, they need supportive care in terms of ventilatory support, supportive care in terms of like we should be able to manage infection, supportive care in case of maybe patient need dialysis, and supportive care we should be able to treat the infection. So it is more important in the first month of therapy, that we call as induction therapy, because most of these complications they start in the first month of therapy. Then how can you, then another problem is the treatment abandonment. So how can you reduce the treatment abandonment? So treatment abandonment is called if the patient interrupts his or her treatment for more than equal to 4 weeks. If patient interrupts the treatment more than 4 weeks, then we call it as a treatment abandonment. And it is a major contributor of treatment failure in our setup, and which is rarely seen in the developed countries. And what are the risk factors of abandonment? It is poverty and cost of treatment, though central government as well as state government multiple like schemes are there for this treatment cost. But most of the people, like once they think like if the educational status of the parents are not good, so most of the no cancer, it cannot be treated, we don't want treatment, will go. And especially if the patient is from a like distance from the center, then there is staying will be a problem around the cancer center. But even if like now many NGOs are helping to stay the patients around the cancer center, but still then if the educational status of the parents are not good, then they are not very interested to take these facilities. And of course, cancer type, if the presentation is late in the advanced stage of the disease, naturally, when we explain them that the chances of the survival rate will be poor, and that will again is a hindrance for taking treatment. And of course, patient gender, that we know very well that they will not be interested for a girl child for a treatment. Then another thing is that adapting treatment regimens in lower and middle income countries. So most of the time when we find that if we are following one regimen which is followed in the developed countries, that gives us good survival rate. But again, supportive care will be needed. Supportive care will be needed. Supportive care will be needed very much for those cases. So we have to balance that whether we can follow that particular regimen which is very intensive but needs supportive care, otherwise our treatment related mortality will be high, or we can reduce our chemotherapy regimen so that our overall survival will be higher than whatever we are following without treatment, or with treatment with intensive regimen but where treatment related mortality is high. So we can reduce the treatment regimen. Definitely it will give us more higher overall survival, as well as it will reduce the treatment related mortality. So that most often is done in lower and middle income countries.
Dr. Sonali, sorry for the interruption. So kindly wind up a little early because we have the second speaker, and I think we'll have a good discussion afterwards also, if something is left. So please kindly wind up.
Yes, sir. So it is, I'm just winding up 30 seconds. So already we have discussed that what are the factors affecting treatment and survival. So as you can see that this leukemia, that is especially acute lymphoblastic leukemia, retinoblastoma, and these germ cell tumors, they have good survival rate. And just 1 second for this, like infrastructure. So we did not have level 3 or level 4 infrastructure for cancer, pediatric cancer treatment. So even AIMS is also like level 2. So with level 1 also infrastructure, we can start treatment, especially where we don't need that much of supportive care. Otherwise in AML or BRCA, then level 2 is also significant. So the multimodal treatment, we know that radiotherapy, surgery, and chemotherapy are the treatment of multimodal treatment of choice in pediatric cancer patients. And initial screening should be done by the general physician or pediatrician, and treatment should be done where it is available. So here, at every individual level, hospital level and level, we should work towards early referral and treatment, and it should be like provided with a fixed number of beds for pediatric oncology care. And the long-term goals should be like optimal health-related quality of life, and patients should be accepted in the society as like his peers. And side effects, we have discussed that side effects of radiotherapy and chemotherapy are there, starting from myelosuppression to hair loss to secondary malignancies like there. And these late effects we are talking about. So late effects may be organ dysfunction like cardiomyopathy if we are giving anthracyclines, growth and development, psychosocial cancer. So patient needs to be followed up for this malignancies. And some myths are there like pediatric cancers cannot be treated.
Can you please, those are common discussion we can have. So please wind up. Time is also a big factor.
So,
Those
sir,
common.
yes,
Yeah.
sir. So take home message. So basically childhood cancers have high cure rate, and appropriate and early screening tests are important, and confirmatory histopathological diagnosis and staging evaluation is necessary. Early referral to a center with pediatric cancer treatment facility improves the outcome, and monitoring, of course, for the late effects is essential. Thank you, sir.
Thank you, Sonali. The time is short. We go to the next speaker, Dr. Susmita Sarangi. Dr. Susmita Sarangi will speak on treatment management of the pediatric cancers. Dr. Susmita Sarangi.
Yeah, can you see my screen?
Yes.
All right, thank you for giving me this opportunity to present about pediatric cancers. And I'm going to actually talk about the journey towards a cure. How do we get to that over 90% survival rates? We're getting there in some cancers, but how do we get there even better? So we can't talk about cure without talking to some of the early pioneers who dreamed that a cure could be possible. There was this lady called Lucy Wills, who actually discovered the Wills factor, which is nothing but folic acid, while she was working in the Hafkin Institute in Bombay, India. And she realized that this folic acid is, when given to pregnant women, prevents anemia, that is the folic acid deficiency anemia. Another Indian, Yallapragada Subbarao, who was from Chennai, actually had moved to the United States and was working in biochemistry in Harvard, and he synthesized this folic acid. And this was a very, very big contribution. He also has discovered many other things. He's a pride of India, actually. He discovered ATP and things like that. But the father of pediatric hematology oncology was this pathologist called Sidney Farber. And his name is after the Dana and Farber Institute in Harvard Medical Center in Boston. So he decided to administer this folic acid to late-stage leukemia patients in the 1940s and 50s. But guess what happened? When the cancer cells got folic acid, they proliferated more and the patients died faster. So then he realized, oh, this is an issue. So let me actually try to develop an anti-folate. So he went back to our friend Subbarao and asked him to develop an anti-folate metabolite. And that is nothing but amnioctolin. And amnioctolin is the early precursor of the medicine that we call methotrexate. And for the very first time in 1948, this is an NEGM publication that showed that there was remission in pediatric leukemia patients. And before that, this had never happened. All these patients used to die. So this was a seminal observation and a seminal finding that led to the path forward. In the 1960s, there were cooperative groups found, and then they tested different chemotherapy combinations. And 1970s, there was NIH support and clinical trials that came into the United States, and supportive care started improving. So then we started actually curing these patients up to around 50 to 70% at that time. So Hope for Pediatric Leukemia Patients was started, and over the in the 1950s and 60s, there were a whole slew of other chemotherapy medications. And actually, these are all the medications which are the backbone of leukemia treatment, even in 2021. We are using exactly the same medicines that were discovered in the 50s and 60s. But what happened is we understood how to give these medications properly, in which combinations, in what regimens. So even though these same medicines were discovered, you see how the survival curves in the 1960s were like very dismal. The line was completely like flat. In 2006, 2009, the line is completely coming towards the 100% mark. So just by knowing which combination therapy to give and improving supportive care, as Dr. Mahapatra had said, has improved survival rates in leukemia, or is improving survival rates. If you look at the treatment, the medications for treatments, I did a quick Google search of the medications that we use. Even in India, the regimens are pretty similar. And these medications are very cheap because they've been around for for so many decades. So they are mostly under 100 rupees. The only one which is expensive is the PEG asparaginase. And I'll talk a little bit about the medicine, but it's pretty affordable, the medications themselves. So what are the principles of getting towards a cure for pediatric leukemia? So how did this happen? So first, it was the advancement and discovery of effective combination chemotherapy. The discovery of asparaginase, the medication alone, it improved the event-free survival rate from 31% to over 70% in the 9-year mark. We also learned to deliver this chemotherapy safely because there are very lot of side effects associated with these medications. So for example, the medications methotrexate, it goes to toxic levels when we give them high-dose methotrexate because that's needed to kill the cancer cells. But we discovered that we need to give a medication called leucovorin at the exactly right time so we can rescue the normal healthy cells, and that doesn't cause toxicity to the normal healthy cells. The other thing is we learned how to prevent infection in immunocompromised child. So even before the pandemic, our hem-onc patients know the value of good hand washing, wearing a mask, and making sure they're not around crowded people. And another seminal thing in pediatric leukemia was the introduction of intrathecal chemotherapy, because we knew that the leukemia cells hide in the CNS, so that intrathecal delivery of chemotherapy was really important to prevent relapse. And then over the last 10 to 20 years, we have done a deeper dive and understood more about the science of this leukemia. So risk stratification, we've discovered how to stratify which are high-risk patients, which are low-risk patients, and then we tailor the medications based on their risk stratification. So for example, ALL, that's B-cell acute lymphoblastic leukemia, is better treated than acute myeloid leukemia. T-cell has worse prognosis than B-cell. The age group that does the best in leukemia is between age 1 and 10, and either of the extremes got high risk features. The higher the white count and presentation, your risk stratification makes it higher risk. And then there is a concept called minimal disease evaluations or minimal residual disease. So after the first month of induction chemotherapy, we expect the leukemia cells to go really low in the bone marrow. And nowadays we have ways of quantifying that by qPCR and flow cytometry, in which we can look at cancer cells at the even if there are 10⁻⁶ or 10⁵ floating cancer cells in the body, we are able to detect them. And if they are positive, then we intensify treatment, and that helps to improve survival. And of course, there's molecular genetics happening. We are understanding why these cancer cells become cancerous. There's always in leukemia cells, there are these genetic abnormalities that start accumulating, which causes these cells to become leukemic. So understanding that has helped to also risk stratify, because we know certain genetic markers are high risk and certain are low risk. So the ultimate goal, because we give chemotherapy, which is nothing but poison to the normal cells, you're interrupting the cell cycle, right? So the ideal medicine that we can give these patients, if we know what the genetic alteration is in this cancer and we target that genetic alteration, and that would give the best promise of cure without the least toxicity. So the targeted therapy was is actually we're using it for a couple of cancers. I mean, a lot of cancers, but two examples that I'll give you is the acute promyelocytic leukemia, which has the 1517 translocation, which is the PML-RARA gene. So in these patients, because there's a fusion oncoprotein, it blocks the differentiation of the myeloid cells in the bone marrow. And if you give them medicines called ATO, which is arsenic trioxide, or trans-retinoic acid, this unchecks this oncoprotein and helps them differentiate. And these patients have some of the best outcomes in leukemia if you can get them through this first induction period, which is usually the more intensive period. And then, of course, people know about imatinib or Gleevec. This has been used in chronic myeloid leukemia cells. And this was the first evidence that targeted therapy alone is sufficient to treat a cancer. So just with one pill, this patient with chronic myeloid leukemia are getting almost up to 100% progression-free survival. And they just have to take the medication for life, but we're converting cancer into a chronic disease by just one medication. There's still going to be relapse, even in the best setups. There's 10 to 20% of our leukemia patients do have relapse, but there's even promise with advances going on for relapse. So you can risk stratify them again when they relapse, and you can cater whether they're going to get some more targeted immunotherapy or we should look for a bone marrow transplant. And now there's CAR T cells and other investigational agents that these patients are eligible for. And of course, this is more in the advanced sector, but even in the resource limited outcomes, a lot of these patients, if they've relapsed a long time, like more than 1 year or 2 years after the completion of treatment, we can give them reinduction chemotherapy and give them up to 50% survival rates again. So just giving you a flavor of these immunomodulator therapies that we have, there's a medicine called blinatumomab that is actually being studied in clinical trials in the United States currently. This is a bispecific antibody. So what they do is take two parts of two antibodies, the CD3, which targets T cells, and CD19, which is present in the tumor cells, and bring them together as a medication. And when you give these cells, when you give this medication, it helps the T cells direct to the tumor cells. I'll show you in the next slide how that happens. So this has shown really good promise in adult studies as well as some pediatric early phase studies, that the complete remission rates are almost doubling if you just add this one medication alone. So the hope is that we can give these more specific treatments and avoid the complications from this, the general chemotherapy agents. So this is exactly how the BITE works. The antibody takes the T cell and brings it close towards the leukemia cell, which is expressing the CD19, and that's how it destroys the leukemia cell. The other thing we talk about is the chimeric antigen receptor, the CAR T cells, which a lot of you must have heard about. So chimera is nothing but in Greek mythology, this mythological figure had a head of a lion, body of a goat, and a tail of a snake. Actually, I prefer to use our chimera, that is the Navagunjara from Mahabharata. And that is also is a mixture of nine animals, right? That Krishna showed Arjuna in the battlefield. But what is chimera? Antigen receptor. So what you're basically doing is you're kind of engineering the patient's own T cells to express whatever antigen you want them to fight the cancer, the leukemia cells. So you're using your own body's immune system to fight the leukemia. So they can collect the T cells from the patient, and they expand and grow it. And like you see the cartoon on the bottom of the slide, this particular T cell has the CD19 expressing. So what it's going to do is they're going to look for the leukemia cells which has CD19, which is almost all B cell leukemias express that, and they go and destroy the cancer cell. So Dr. Mahapatra alluded to these survival rates. We are getting there in other cancers too. Across the board, it's about 70% for most of the soft tissue cancers, whereas like Wilms tumor, it's almost up to 91%. And Hodgkin's lymphoma right now presently has the most best survival outcomes to around almost 97%. So just a little bit of principles, and Dr. Mahapatra did this, so I'm going to touch about it briefly. If there is a solid tumor, our surgeons are our best friends. So if they can do local control and take that tumor out, like for example, in this picture, the Wilms tumor is coming out, and if they can resect it completely without rupturing the tumor and the margins are free, then that is going to give the best survival outcomes for a patient, for a pediatric patient. Because oftentimes they can downstage the tumor, so they're going to get less treatment. But unfortunately, if the tumor spills or if it's adherent to surrounding structures, that's going to upstage the tumor. Of course, we talked a lot about chemotherapy. That still has a big role, especially in metastatic disease, or even if you take it out, sometimes it's needed to mop up any tumors, any circulating tumor cells. And the role for radiation, it helps control the tumor bed. And there are a few ways of doing that. So it basically paints the area where the cancer is, and it destroys those cells from proliferating further. So it gives you better survival outcomes. So even after you cure these patients, there is a lot of things that we monitor them for. Currently, in developed countries like the United States, there are more than 400,000 cancer patient survivors. And of course, like Dr. Mahapatra alluded to, there are a lot of long-term side effects that we look out for. Up to 2/3 of childhood cancer survivors will experience at least one of these side effects, like organ damage, infertility, growth alterations, and 1/4 of survivors will face a late effect from the treatment. So just summarizing, the key takes: children are not mini adults. In a lot of things, they are stronger than adults because they actually do the stronger therapy or more aggressive chemotherapy is well tolerated in children, since they don't have underlying diabetes or hypertension and other comorbidities. Treating cancer comes from a collaborative multidisciplinary team. So we need a lot of coordination within a good pathologist to give us an accurate diagnosis. That's key. Our radiologists are key to figure out where to stage the cancers properly. And then the nursing is really important to help administer these agents. So there's a lot of, and surgeons, of course, are key to taking out there's a lot of multidisciplinary support that happens. The ongoing research is key to succeed, and personalized medicine is coming up, and that's for targeted therapy, and that's the way to do this in the future. So basically, personalized medicine is like if you can find the specific genetic alteration that's causing the cancer, you can find a medicine, like there's so many tyrosine kinase inhibitors, there are all these targeted medications that hopefully you can give this one pill, just like our CML patient that we talked about, and you can help survive, make this patient have a chronic disease, or sometimes even cure them just with one, the targeted treatment for the medication, for the cancer. And that's it. Thank you so much for giving me this opportunity again. Thank you to Behra sir for thinking of me. And this is my contact information if you ever have any questions, concerns, but we'll open it up for discussion.
Thank you, Susmita, for your nice presentation of pediatric cancer, the journey towards the cure. Actually, this cancer means everybody is thinking about some fatality, something like that. But good treatment can also have to better survival. In the chat box, no question. Any questions from the participants?
Dr. Behra, I want to ask one question.
Yes, yes.
It's nice to, Anjali, to see you after a long time. Do you recognize me? I'm
Dr. Mahanti, yes, of course I recognize you. I remember you very fondly.
Okay. So I want to tell you regarding this personalized thing. It is very, told thing, particularly in adults like breast cancer and all. So do you think there is any oncogene or anything that it can predict that besides Down syndrome and syndromic, I'm not telling, those are predictions are there. But any oncogene for personalized medicine is still in children have been identified?
Yes, actually in the solid tumors, currently we are doing, we send it for tumor profiling. So we are able to like do a next generation sequence and look for any abnormalities that are present in the genome. For example, I'll tell you, I have a 9-year-old who has a high-grade glioma, and she was expected to die because it was so aggressive in her brain. And we sent it for this genome profiling, and we found this cyclin repeat sequence, which is making her cells proliferate a lot. And then there's a medicine called palbociclib, which inhibits that particular pathway. So we find a pathway to block by the genetics, and we have a medication for it. It actually improves survival rate. So this patient is still alive for 6 months after starting this medication, and her tumor is actually shrunk, which is incredible. And this is what personalized medicine is. You can make a uncurable cancer, stable, or even make them survive for a longer period of time. So we're slowly getting there. But we are tumor profiling pretty much all our solid tumors, especially. Even our leukemia patients get a full genetic evaluation, like in the cancer cell itself. Again, like I said, it's tumor predisposition is another category. But if you can find what made the cancer cell go crazy, that genetic alteration, and if you have a medicine to checkpoint that or inhibit that, then that there's a promise of personalized medicine.
Okay, anything on neuroblastoma? Any advance?
there is a lot of advance going on with neuroblastoma, especially with stage 4 neuroblastoma. There's immunotherapy, there's MIBG therapy, there is all-trans
Regarding
retinoic
the
acid that we're
personalized
using.
medicine, I'm telling personalized medicine in neuroblastoma.
So immunotherapy is where personalized medicine is going. I mean, it's more, it's a little bit more general, but I am not aware of specific medication that's personalized to it. It's a little bit of a wider net. So you try and get your immune system, you try to see if you can give MIBG therapy to target the cancer cells. But yeah, stage 4 neuroblastomas are still doing pretty, we don't like our survival rates with that, but we're hoping to improve it with multimodal treatments.
Okay. Thank you. It's nice.
You're very
to,
welcome. Nice to see you,
after
Dr.
a long
Mahathir.
time. Yes. Can I ask one question to Sonali?
Yes.
Sonali, actually, I thank both of you for so nice lectures. Sonali, you are telling that in developed countries, in comparison to as incidence is concerned, you are telling that in developing countries, the overall cancer rate is more. I think that's the thing you told.
Per million population, sir. If we calculate our this population number is very huge. So if we calculate that per million population, their incidence is more than ours, but it is thought that maybe we are missing much more than them.
No, in percentage, is it where it is more? In Western or Eastern?
No, sir. Actually, the absolute, like if we calculate, because our population is huge, so if we will calculate as per million, the incidence, then the per million, it is coming less, sir, in our setup.
Achha,
It is around 50 to 60 per million. But as a whole number, it will become more. But the thought is that it is still much more. We are missing out. Because when we are comparing with Western countries, their incidence is around 80 to 100, where we are at actually 50 to 60%. So maybe we are missing much more because of lack of diagnosis and other things than them.
Okay. Thank you.
I think just to also on the point in the developed countries, we have a lot of cancer registries. So that's how we get more accurate information of the actual incidence. Whereas in India, except for like Dr. Mahapatra said, in institutions, what the rest of the country is seeing is not being reported. So there's a lot of patients. There is so much more cancer in India, but we are not able to capture those patients.
And sir, like you asked this neuroblastoma. So this neuroblastoma is actually much more frustrating because there are so many this re-stratification and for prognostication. So many things are there, but literally very little for the treatment. And as you have told, actually monoclonal antibodies and this 13-cis retinoic acid, these are used. This as Dr. Susmita has told for this. Antibodies are being used, but these are not actually child specific. These are more generalized, used for everyone. But this stage 4 neuroblastoma is frustrating for everyone in the developed countries also.
Yeah, it's across the board. We try everything. We just literally put the kitchen sink at them. That's called a kitchen sink approach because we do surgery, radiation, immunotherapy, chemotherapy, and they still have not good outcomes. So we're getting slowly, hopefully, someone finds that personalized medicine for these patients because that's really needed.
Any other questions? Dr. Susmita, what about the expense about the bone marrow transplantations?
You mean the expenses?
No, I mean regarding the
experience. Yeah, experience. So bone marrow transplant is offered for relapsed leukemia in the relapsed leukemia setting. And certain leukemias like AML, acute myeloid leukemia, if they have certain high-risk features and they're not responding, they'll get early into bone marrow transplant. Again, like India, it's not available in all centers. So we do have to send them to, like my center doesn't have bone marrow transplant. We have liver and intestinal transplant. We don't have BMT. But in Washington, DC, we have Children's National Medical Center. The only thing is that it's available a little bit closer to the patient's home. So we don't have to send them to like, PGI or Vellore. So it's not like crossing state boundaries. Usually in your state, you'll have some access to bone marrow transplant. And if you have a matched sibling, that is the best, outcomes that you can possibly give. And the other thing is we don't have to worry about expenses because of insurance, which is a huge drawback in low middle income countries. Because when you think of transplant there, even with subsidizing and with the government, it still is a lot. It's very expensive. So that's something that is reserved for patients who relapse or have some acute high risk features. But like I said, it's that 10-20% who relapse. That's when we start thinking whether bone marrow transplant, or you think of immunotherapy, whether we can give them into remission by doing something like a BiTE antibody or a CAR T cell. Although if you see the expenses, the CAR T cells are probably more expensive than a bone marrow transplant at this point.
Yeah, true. Cost major drawback in our setting.
No. I'll come in just for a moment, Subal.
Yes, sir.
As regard the cost is concerned, I think I know, everybody knows here, everything is free in SCV, and for that matter in the state. Nowadays, we are utilizing everything. You think about any drug, the cost is immaterial. So cost is never a factor. And we have a bone marrow transplant center also, even though they have not gone for this thing. So the cost is not a factor in Odisha at least. This much I can say. So I don't think it is a disadvantage being in Odisha also.
Yes, sir.
The treatment is, you can spend 20 lakh for a patient. There will be no objection from any quarter if it is required. So I fully agree. Now the government has already made all the provisions for everybody, rich, poor, alike. The cost is not a factor. So you can give your viewpoint.
Yes, sir. Then definitely we should explore this option for treatment of bone marrow transplant in leukemia patients.
Sir, can I come in, sir?
Yeah, Ravi.
Sir, yes, I agree that the cost is not a problem because the government of Odisha is committed fully, be it bone marrow transplant or any expensive therapy, it completely will be borne by the government of Odisha. So what is the concern is that, as you know, in any malignancies, be it leukemia or lymphoma in pediatric or adult, the fast treatment is the best treatment, because once you miss or once you compromise with the fast treatment, so treating the relapse or refractory leukemia or myeloma, refractory leukemia or lymphoma is a big problem in developing countries like India, also including India. So the fast treatment should be done in the best possible way.
I hold up.
And my second point,
No, just a minute. You have given an observation. I need to know more about it. Why the constraint in India for relapse treatment?
Because if you go for the relapse or refractory, the tolerance to the aggressive chemotherapy, what is being considered as a standard protocol for relapse or refractory, is extremely poor. Because the bone marrow reserve is completely compromised by the repeated chemotherapy. So their tolerance is extremely poor. The costs are exuberantly high.
Professor Jana, it is same for everywhere. I don't think it is specifically for India.
No, sir, it is same, because if you compare US and India, there is a huge difference managing the refractory because of the workload, infrastructure.
No. What is the disadvantage? You said only in India. That is what the thing I did want to buy that.
Okay.
Relapse is a problem. Everywhere there is a problem.
So relapse is a problem everywhere, but more so in the developing countries, because of this is the reason. And second is, the bone marrow transplant is going to dominate in the setting of the refractory or the relapse leukemia, because whatever you go for the immunotherapy or CAR T therapy, as on today, these are not the standard of therapy, exuberantly high. So bone marrow transplant is going to dominate. But what is the main setback is not the cost. The main setback is finding a suitable donor, HLA matched donor. But the good news is that now the haplo identical means that is with 50% HLA match. Now the transplant started, and once it becomes standardized in India, I think this is going to really dominate so for the management of refractory or the relapse.
Thank you, Dr. Jana. Thank you, Dr. Jana. Professor Mrityunjay.
Okay.
Dr.
Principal sir, good evening.
Good
Just
evening.
Dr. Jana, I want to ask one thing. Do you think that there is resistance to if it is suppose failing, first time treatment is failing, do you have a term like resistance to drugs or what?
Is that the first or the failure to the
No, I think let's not go into that. We have got two very eminent speakers, so we can take their view. Does it have a failure in relapse? I don't know why this thing has been brought in. Dr. Sarangi?
Yeah, so if the first line of treatment, like Dr. Jana was saying, the induction period, the first month for leukemia is the most critical period. So if you can get them into remission in that first period, even high risk leukemia, or whatever features, it becomes that what we call response to initial induction is the critical period. If they do not respond there, then it becomes what we call refractory leukemia. And that's when we start thinking, okay, this
With this person.
So if they don't respond in that first month, then we are starting to look at refractory disease, and that becomes when we start entertaining maybe this patient is not going to, if the most aggressive first month, with so many chemotherapy agents, they were not able to get into remission. So we need to change our mindset a little bit. So we start looking, if they have HLA matched donor, if, for example, if they have a sibling, we start typing them and see if there's HLA match, they're HLA matched, and then we're going to think of doing a bone marrow transplant sooner than later. Because it's the concept of resistance is there. So they're probably not going to respond to further chemotherapy. Actually, in the current protocols, you'll give them another month as well. So you do the consolidation part. And so after the second month, we look, if they're still not remission, they're still refractory, they're not getting into remission, then we will refer them for a bone marrow transplant.
Thank you, Dr. Sarangi. Professor Behera, I think your approach, just a minute. Professor Behera, it is almost 5:15. I think we should wind up. Kindly offer a vote of thanks and invite all of them for the Platinum Jubilee.
Thank you, sir. This is a very
Professor
because this cancer topic that will discuss time and again. So with the time for the give the vote of thanks to both the Dr. Subhasola will give the vote of thanks. Thank you, sir. Good afternoon to all. Respected Dean and Principal, all invited speakers, esteemed faculties, my teachers, my colleagues, and dear students. On behalf of the Department of Pediatrics, SPPGAP and SC Medical College, we would like to thank our Dean and Principal and the Scientific Committee for this opportunity to conduct this pre-platinum Jubilee CME. Our sincere thanks to both the speakers, Dr. Sonali and Dr. Sita, for being here with us and also giving some light into the management, diagnosis, and challenges of pediatric cancers in India and abroad. We also would like to acknowledge all the participants who have joined with us. My special thanks to Mr. Devasis and the team for all the technical support. And we hope to see you all virtually or in person, as our Dean and Principals have told, during the main event of the Platinum Jubilee celebrations scheduled in the November 26th, 27th, and 28th of this month in November, to depict the past 75 years of glorious history of SC Medical College. Once again, thank you all, and our best wishes for all to continue to stay safe. Thank you all. Thank you.
Thank you.
Thank you very much. I have to start my work day now, so I've got to rush. Take care.
Thank you. Thank you.
Thank you.